This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Ms. Ciera Scott. Welcome, Ciera. It's a pleasure to have you with us.
Thank you so much. It's a pleasure to be here.
Now, we're going to have a little discussion tonight about something that I think is a major issue in everyone's life, and that is pain.
Absolutely.
Pain is a big deal. And before we get into that discussion, let's talk a little bit about your journey through life. So you work with us at the Institute as research coordinator, is that correct? And right now, you're also a student, is that correct?
Indeed. I work two jobs and working very hard. I absolutely love my journey so far.
And you're going to MRSA? You're getting your graduate degree there?
Yes, sir. I got my bachelor's there, but I'm also working on my master's currently in clinical mental health counseling, and I'll finish this December, so very excited about that.
And so you're better than the average bear? Is that the logo? Well, is that
I guess it's just a little bit smarter than the average bear.
Is that what they say there? I don't know. There's Yogi out there. Well. So you've been with us for several years. Is that correct?
Yes, sir. Since December 2008.
Right. Well, that's great. And we can maybe just start off with some of the work that we're doing at the Institute. And I think you've been involved in one of our projects with postoperative pain.
Yes, sir.
And using some medicine to minimize postoperative pain, which turns out to be a big deal, isn't it? I mean, why don't you talk a little about that? Let's tell us about that.
Well, what we're doing, this study that I'm currently involved in is grant funded by Eli Lilly and Company.
Yes.
And we are working with duloxetine hydrochloride, which is commonly known as Cymbalta. Most people know it as being used as an antidepressant, but it's also FDA indicated for use as a pain management agent with people who have fibromyalgia, diabetic neuropathy, and I'm sure people may have seen the commercials recently for chronic back pain.
Yes.
So it has many uses, but we're focusing on how it helps with postoperative pain in our patients having surgery through GNI.
Now, I might just bounce the basketball a little bit on this. So, actually, there are different ways to control pain, and it's a very complicated nexus between when you stump your toe and when the brain perceives pain and distress.
Absolutely.
And the sensation sort of goes up from your toe through a lot of complicated pathways to the frontal lobes, and there one perceives that they hurt, there's suffering, and there are all kinds of things that go on. And what we'd like to do is not to give opioids, which they have lots of bad things attached to them. They're addictive.
Yes.
They have lots of negative impact on different organ systems. So we're searching for ways to minimize the amount of powerful pain medicine we give people, and we're trying to do something that has an impact on a different part of the brain. And what are we up to here? Let's discuss that.
Well, I know what I've seen thus far in our patients who are participating in the study. Most of them before surgery are at least taking at least 2 opioids, whether that be Lortab or Darvocet and that sort of thing. And so what I'm seeing with them is they've been using it for a very long time.
Yes.
And of course, we know the negative impact that long-term use of opioids can have on the body, and especially the dependency aspect of it.
So really, one of the things I think I'll say this is, as a physician, what we see in our world is there's an enormous amount of pain medicine out there.
Yes.
And people are using it many times for good purposes. No one is going to quibble about a person that has cancer pain or some horrible injury that the only recourse is these kind of medicines. But many times people have had long-standing use of these opioids, and then their body becomes habituated to the opioids, and so the stress of surgery or any kind of untoward event in their life, that opioid use goes up to the patient's detriment. So we're trying to cut down on that.
Absolutely.
So how are we structuring our study? Maybe you could talk a little bit about that.
So what we do is we pre-assess our participants prior to having surgery. We first see them maybe 4 to 7 days prior to surgery, and we're assessing them on many different factors. We are assessing for mood, of course pain primarily,
yes.
Overall functioning both physically and emotionally, and then just their overall general health, their ADLs and how they're able to undergo all their activities that they need to throughout the day. So we're basically getting the big picture of how they're doing before surgery, and we also assess them 1 month after surgery and then 3 months after surgery. So we have 3 times during their participation where we're assessing them on so many different factors.
And this is a rather, we've talked a little bit about different levels of evidence. So there are different, I think the audience may have heard us a little bit about this. What goes on in science and medicine, there are thousands and thousands of papers out there.
Yes.
And they have different levels of rectitude in each of in different kinds of papers. And the highest type of evidence would be these type 1 evidence and double-blinded. And is this that kind of study we have?
Absolutely. It is absolutely level 1 evidence. It's double-blinded, meaning that neither I nor myself, neither myself or the participant know whether they're on the drug or the placebo.
Yes.
And we also control to make sure that they are, taking an opioid usually during the process of their before surgery and after recovering. And we have so many different factors that we're measuring them on that we're making sure that we have strong power behind whatever data that we do get from our participants.
So we have people that are going to have a spine operation, and then we're trying to see if with a selected group of patients, if we can give them a medicine that's not an opioid but has a tranquilizing effect.
Yes.
And the idea is that maybe if you're a little more relaxed when someone goes through surgical stress, then it would be possible to take less opioids and presumably leave the hospital sooner, have a better recovery period, get back to normal activities. And that's a very, very important thing for us to undertake in our country. One of the issues out there now are escalating healthcare costs. And I think one of the ideas is the healthcare system and the physicians and their associates making huge efforts to find ways to minimize cost. And if we can get a patient out of the hospital quicker and sooner, then an enormous amount of money is saved. So that's sort of what we're up to here. And
yes.
Do we screen patients? So not everyone can get in this study, is that correct?
No, sir, not everyone. We screen to make sure they don't have any major psychiatric issues underlying themselves. Of course, the main thing that we screen for is major depressive disorder and anything else of that nature. And they, in order to participate in a study, they cannot be taking any other psychotropic medications. Anything for depression, anxiety, bipolar disorder. We will accept those who might be taking, something to aid them with sleep, but outside of that, they cannot be taking any other.
So we want to have sort of a pure population.
Yes.
And I'll just make the case that one of the penalties of life, you could say, is depression. And we see many times that people have a level of depression. And one could also make the case that in post-industrial societies, the level of depression may be somewhat higher than in societies that are closer to a state of nature. So it's very common for people to have some depressive disorders in our country. And it particularly has an association with age.
Yes.
So one of the things that happens as one goes through life is in the sunset decades, maybe I'm in one of them myself.
Not yet.
Not yet, I hope not. But what happens is the brain, the neurochemistry in the brain is changing, and so neurotransmitters are diminishing, and often we enter something called involution melancholia. So people that are older, they get very sad and depressed, and that has an impact on how well they do after operative intervention for pain. So we try and exclude those people. We just get down to a pure population. And how long, the study's been going for how long?
The study has been going on since March of 2009.
Yes.
And at the moment we have a total number of 92 patients who have been assessed. And of course some of the patients are at different points of the study.
Yes.
But we have several who are continuing to be active. And we hope to be completed, you know, maybe around this time next year, with everything wrapping up and with our data analysis.
Now, is there a period of time that's necessary to do this study? I mean, why does the study go so long? I mean, what are the reasons for that?
Our main thing is we hope to have an end number of participants of 140 to 150. So that's why we're just continuing enrollment till we reach that number. So we'll have more power behind whatever results that we find.
Now, so I mean, just for the general audience, one of the things going on is that we're trying to we have to get a sufficient numbers for our statistical analysis.
Yes.
And we won't get into the vagaries of how we do this, but the takeaway message is that if there are only a few patients in the study, the random chance of things happening is much higher. So we can speak with greater statistical authority if we have a certain number of patients.
Absolutely.
And I think our statisticians picked the number of what was the number we picked?
140. So that's our end goal.
So we think we need that number of patients to determine if something is really pretty powerful.
Yes, sir. Of course, we're hoping to cover for dropouts that we may have throughout the study, or those who might have few adverse events occur while they're in the study.
So we have to. So there's a lot of in this kind of study. There's a lot of statistical probability that happens. We have to pay very close attention to the patients that might, for some reason, drop out of the study. Why would a patient drop out of the study?
From my experience, mostly maybe just withering disinterest in the study. It's hard to keep someone active without. That's one big part of being a participant, voluntarily participating. And then we've had just a very small number who may have had some discomforts of nausea or maybe slight dizziness when taking the medication. So they decided to withdraw. But outside of that, most participants are very motivated to participate, and they enjoy being able to, donate themselves to science.
And this actually is that's a good turn of phrase. There's no financial reward for people doing this, is there?
Actually, there is.
Well, I've learned
since it's
something.
grant funded.
Oh, really? Are they getting some money? I've
is.
learned something. Tell me about
Yes,
that.
sir.
If you stay in that,
they have to complete the entire study, but at the end of their participation, they do receive $100 as compensation.
Well,
so
I think what can you do with $100 these days? There must be something. I mean,
fill up your tank, maybe.
Or you can, I don't know what. You could probably eat some hamburgers for $100, but it's
right.
So there's a de minimis. It's almost an honorarium. I mean, it's really an honorarium.
Just a way of saying thank you.
But it really is. People that do this are interested in the general societal welfare. And now, one of the things that happen in this kind of studies is sometimes, if the results are just going crazy one direction or another, we either say we're going to stop the study or there's something extraordinarily powerful underway here. And we're watching that, is that correct? And nothing, so we have some hints this is going to work out pretty well, but nothing is discouraging us from continuing the study.
Absolutely not. There's nothing telling us to halt it, actually. As far as just preliminary results that we've seen, there's some trends that are supporting the idea that older adults, and we split our population from at the 55-year mark, that those 55 and above are, after surgery, are experiencing less depressive symptoms, are reporting less pain, and they're also reporting just overall general health. And so what we want to see as we produce more numbers in enrollment is see kind of examine what kind of factors are helping older adults, and I'm talking about very much so surpass their younger constituents in that way. So those are some of the trends that we're hoping to follow as we go along.
Now, one of the things is, we could sort of hypothesize that we made the comment earlier. One of the things going on with older people is they tend to have some endogenous depression, just referable to the changing neuronal chemistry, just like maybe the muscles aren't quite as, if you're, 66 years old, your biceps are not the same way they were when you're 21. the same issue with
It's
the
your
way
brain.
the brain is functioning. So we have a change in neuronal chemistry, and so in some ways this Cymbalta is playing a role in neurotransmitter action up there, and maybe that's why it's working in older people.
Absolutely, and of course that's something that we're hoping to explore further. What is it about the duloxetine that is having this kind of effect in our older population, and a positive effect?
Yes, yes. And so one of the issues that I think we've spoken about en passant here is the idea of outcome analysis and the complexities of outcome analysis. And one of the things that's often measured is pain, postoperative pain. So I'm going to just go off on a tangent slightly.
Okay.
With your
I'll
permission,
follow.
Sarah. Okay. So the idea is that right now in our country, in our society, we have a big change in our healthcare apparatus. It's coming down the pike. We're going to have big changes. And it may well be that a lot of those changes are going to be directed by external forces, either, I guess, extremely powerful insurance agencies or government fiat. And one of the things that will occur is they will put in treatment algorithms that say you have to do this or have to do that.
Okay.
And one of the things that we've spoken about is many of those algorithms are based on the presence or absence of pain and the studies that talk about pain. But it's such a complicated thing, isn't it?
Absolutely.
So pain can be, for one population, that maybe they're depressed. They may have a very high pain threshold, and the studies and literature that exist in healthcare and medicine may not take that in total consideration. So one of the things that we need to be very cautious about is the medical evidence that exists in general scientific literature, using that evidence without very, very careful assessment to enforce some kind of universal guidelines on our patient population. And one of the things we can see here, just in this study, is the idea that we have some kind of impact with depression possibly, and the impact of mild antidepressant medication reducing pain. So you could say that maybe a younger population is going to do better than an older population where pain is being assessed for outcome analysis. And that may not be in the literature. So I hope that was a rather circuitous conversation about some of these difficulties.
I know that it may. I know intellectually, I think you would believe that the younger population would respond better to this antidepressant and do so much better post-operatively. But what we've seen so far is kind of the complete opposite.
Yes, yes.
And so that's definitely something that we want to explore further as we continue assessing our patients. Okay, but also just the importance of the possible use of antidepressants as a pain management agent instead of the heavy dose opioids is such a tremendous difference that it can make as far as healthcare costs are concerned, of course. I mean, and especially and also in decreasing the amount of dependency that our patients are having, because I think that is the number one issue that I personally see as the research coordinator over this study, is patients becoming so dependent on that medication as their one source of relief.
Yes, yes.
And hopefully seeing that they have another option that isn't so damaging to their bodies and psyches.
Yes. That's a big issue, isn't it? I mean, the amount as we assess our society, our country, as we try and go through healthcare reformation, and we're thinking about some ways to decrease costs. A lot of what goes on, I think, is patient responsibility in putting the situation together. And many people have found themselves, for better or worse, in the role where they're taking strong pain medicine. And many times, this is a physician that's prescribing this medicine, and if you need it, you need it. But there are a lot of people that really become very dependent on this, and it's a very difficult thing to break, isn't it? It's very tough.
Absolutely.
Once you've been on pain medicine for a long time, and I'll just make the comment, I mean, there are lots of people that have had many eminent people have had enormous, I guess, dependencies that have developed inadvertently. I mean, we can name one, physicians often, we can name Sigmund Freud. I mean, we'll throw that name out.
Absolutely.
He's a person that actually became addicted to cocaine. There are many physicians out there. Another person is Dr. Halstead, who was the father of American surgery, you could say. He was one of the great giants at Johns Hopkins in the early part of the 20th century, the last part of the 19th century, a very eminent guy.
Right.
And he was doing experiments on his, he was trying to come up with ways to use cocaine to minimize postoperative pain. And he made the mistake of getting a little too involved with it, and there we go. So there's a person that's become addicted, and it's a big problem. And if we're trying to have a healthy society that doesn't that minimizes healthcare expenses and is productive, that's one of the things that needs to be considered. There's a lot of discussion about the gross amount of money that goes into the healthcare expenses. But what's maybe not so considered is the use of excessive amount of pain medicine generally that depresses human productivity.
Absolutely.
So finding ways to reduce that is a big deal. Now, have we had any, I'll just say, maybe we haven't looked into this, but have we seen any evidence in cost changes in the treatment of people receiving their total hospital expenses or stays? I don't know if we've looked into that. Have we?
Not so much that aspect of it, but we do monitor their opioid use throughout the study.
And how is that working?
I would say that overall it does decrease over time. And so what we're seeing, hopefully what we'll see is that as they become, as they see positive impacts from taking the Cymbalta, that they'll become less dependent on those heavy opioids and not be having to, spend so much money on pain management, and especially in that long-term use aspect.
Yes. One of the other things we're looking into is the idea of in general, the opioid dependency. We have other studies underway, but when patients come in and they have a neurosurgical procedure, they frequently have what's called a morphine pump. And the idea is that if you're uncomfortable directly after surgery, you can just regulate your own pain requirements by pushing a little button. And so when you push this little button, the body receives, jolts of varying kinds of narcotics that will ease the postoperative pain. And one of the things we're looking into is the idea that some people have been on so much pain medicine that that number needs to go up. And if we don't give them enough, they're so tolerant. If we don't give them enough pain medicine, then it winds up prolonging their hospital stay. They're very uncomfortable. Regulating that's the postoperative pain management is a big thing. Another thing that I think is necessary to deal with pain control is fear. I think that's the big part of I think that's, at least my observation has been this. When people have some kind of substantial operation, they're facing a substantial operation. One of the biggest things is they're frightened about hurting afterwards.
Of course.
And just to be reassured that you won't hurt is a big thing, and actually that makes things better. So we want to try and keep people comfortable afterwards. And there are big efforts underway to do that. It's a complicated line to walk, is it not? To give people too much pain medicine or not enough. Generally, we try and just hit the right target there.
But I think it'll be interesting just to think about how our culture is very intolerant to pain. We do not like to suffer. We do not like to hurt, and we want that instant gratification of having the pain go away.
Yes.
And so that's definitely just something to consider. But with my patients, I've seen that fear is so powerful, especially if this is their first surgical procedure.
Yes.
And so they want to limit any kind of adverse events that they may have with regards to the surgery. So that fear is definitely a factor, and I see it when they're sitting across from me and when when they're participating in the study, especially right before surgery. It's a very powerful thing, and it kind of it subdues their intellect and keeps them from really thinking about how many pills am I taking? I want more, I want more, I want more. I want to numb, I want to numb, I want to numb, instead of thinking about the actual negative effects that it may have.
And one of the things that happens with the pain situation is that sometimes people have psychological issues, and if you take a lot of pain medicine, it's possible to blunt in the anxieties of life.
Right.
That's not an uncommon situation, is it?
Oh, absolutely not. And of course, from my end, I'm definitely interested in the psychological, psychiatric aspect of it.
Yes.
Because, of course, while some of our patients may not meet DSM criteria for a psychiatric disorder, there may be some subclinical aspects going on.
Yes.
Especially just with, living life, you have your normal ups and downs. And again, I think from American culture, we do not like hurt or worry or pain, and so we've become dependent on that instant healing.
Yes.
And so hopefully by exploring how Cymbalta is useful, it will lessen that dependency throughout, especially our post-operative patients.
Now that's one of the biggest things out there, and I'll just be a little circuitous once again here, is discussing all of the extraordinary amount of money the society spends on healthcare. It's several trillion dollars. I'll repeat that, trillion with a T.
Not B.
And a huge amount of that money is spent in some way for pain control or pain relief. So if you see a doctor, well, your foot hurts, that's the reason you're going to see a doctor, or the chest pain is almost any disease process that requires treatment has at least some part of it is connected with pain.
Yes.
And the complexities of this is so powerful. So different kinds of therapies are undertaken out of this $2 trillion to control pain. And in our society, we have how can one say it? They're very, we're very sensitive to pain compared to other societies that have a more robust nature in a way. And that so we might be over-treating some disease processes. That's possible. I mean, and one of the things that happens too is in the analysis of our treatments, the vagaries of pain control and pain relief may in some ways lead us down false directions. So if in the outcome analysis of a particular therapy we say, well, the pain relief was 20% or 60%, that's quite complicated, isn't it? Very complicated.
There's so many factors you have to take into account when examining the issue of pain.
Yes. And this patient, so we actually, I think this study has been presented at least once, and
it has.
You did that, I think, at the
Yes, sir. I did. I presented at the annual spring meeting for the Georgia Neurosurgical Society in May. That was at Sea Island, and just presented our preliminary results as far as the
good.
study's
So we're
concerned.
blowing our trumpet, and I think the plan also, the work has been accepted for a presentation at the National Neurosurgical Meeting in Washington, which is a big deal. So obviously we're making some points on this.
Absolutely.
But we're still not ready to say anything much about it, are we?
Not yet. We'll keep our lips sealed until we have our final number where we can present our data with more confidence. But also just to say, it also has, the study has been also accepted to be presented as a poster session at the Gerontological Society of America's meeting, their annual convention, which is in November in Boston.
Oh boy, well that's
get
good.
A little press.
So, that's right. No, that's good. I mean, this is what we try and do at the Institute. We do these kind of things. And we have a number of additional things in the hopper, additional studies.
As always.
Well, all right, Ciera, I'm going to give you what comment would you like to make? You want to say hello to your family? You've got 30 seconds. Where's all this going? You have 30 seconds. Yes.
I would first off just like to thank you for this experience of just being here and being able to discuss my research, and also the power behind my inspiration is my family, especially my mom. So I would like to just thank her for raising me and putting that drive and ambition and extreme wondering about life inside of me. So that has always been my push through whatever I do, but especially research. So that would be my last comment.
Okay, call your mother's name out for the world to hear. Go ahead, call your mother's name out.
Thank you so much, Vicki, Dr. Vicki Purdue Scott. I love you very much, and I appreciate you.
Okay, well, thank you so much for coming,
so
being
much,
with
Dr.
us tonight,
Robinson.
Ciera. Thank you.
Thank you.
Thanks.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.